at the color, at the scent, volume, right? What's in there? Ew, I don't like that. You're a detective now. You gotta put your Sherlock Holmes hat on. It's yucky, but you have to investigate, right? Nasty damage in a pancreas gland in her mouth. let me know if you find something that helps, that works. No, but it's true. Yeah, exactly. It's the tissue is not made for that, so it's going to do damage. And so so if the client is producing some vomitus, they're having bouts of emesis, I want to be looking at what they're producing. If I can measure it, I'm going to try to measure it, right? There's usually measurement symbols on many of the basins and those kind of things. You just have to look for them, okay? But, what color is it? Is it full of blood? Is it bright yellow? Is it brown, flat, beigey colored? Is it green? Is it full of foam and bubbles? Is there black stuff in it and you can't tell what it is, but it looks like there's black stuff in it, right? So see, what does that picture look like? You are those eyes. Describe, document, and report if required, right? Well, heck, if you're seeing like blood in people's vomitus, please call for help, all right? But measure, report, record as best I can. Right, remember, don't stick your face in it. Smells like blueberries. No, we're gonna waft it, right? Does it smell weird? Is it something why does it smell like gasoline? I don't know, chart that, right? If it's not something that you're expecting, that means it's way outside of the normal, right? So if it looks like strawberry and bubblegum, I mean, great. It looks like strawberry and bubblegum, but if it doesn't look happy like that, then we need to really be careful and we need to pay attention to the language that we're using to describe things, okay? We might be saving a specimen to send to the laboratory, right? Forward thinking. I'm a PSW, I'm taking care of my client. I know that she had a few bouts of emesis overnight, so I asked before I even go take care of her that day, do we need a sample? If she throws up today, should I be getting a sample? So I know already, I'll put it on my task list. If Veronica has an episode of vomitus today, get that sample. I'm not going to wait until I'm told later. I'm going to ask, right? Have we sent a sample away? I'll grab that today if she has another one. Just that thinking, right? That critical thinking. If you're seeing it, ask. You can ask that question, right? You're calling to report the change or something's going on, you can ask. Disposing of it after it's been viewed. Sometimes staff will want to visualize it if they're available to see it. I've done that before. Can you hold that for me? I want to come and look at it. I'm just going to finish typing this thing, and then I'm coming to look at it. I want to look because I want my eyes too for my notes, right? So maybe you might have to save it for a minute.
On this school.
But once it's safe to dispose of, how are you going to do that? Maybe in the toilet and flush it, perhaps. Depends, right? Facility protocols. We know what we're supposed to do with things, depending where we are. Okay. Try to get rid of those odors, right? It doesn't feel nice, sticky. You feel yucky. Oftentimes people feel embarrassed when they vomit, right? So we're also going to want to provide some of that like emotional support and comfort as well, right? People might be scared. If I have some cognitive impairments, I might not understand what's actually going on. So it might be extra scary, right? And I've got somebody, hovering over me, trying to put a bucket near me, and why are you? So, thinking about our client in context, right? What is their experience right now? You know what I mean? Let me just check here in my comment section. Kate Nostran was there. Next, I'm going to talk about Gerd. I feel like I assigned Gerd to a group. Did we? Was there a...
Yeah, that's it.
Yay!
Okay, so GERD, or gastroesophageal reflux disease, is a common digestive disorder that causes heartburn. So the cause of GERD, although it's unknown, it happens when the muscles at the end of the esophagus and the start of the stomach, they relax at inappropriate times, allowing the stomach acid to go up into the esophagus. So digestive disorders impact like the proper breakdown of food for absorption into the body, and the elimination of solid waste. And I wanted to say that heartburn is the most common symptom of GERD, and heartburn often refers to a form of indigestion felt as like a burning sensation in the chest caused by acid regurgitation into the esophagus. So you can imagine all of a sudden, inappropriate times, and like kind of random,
thank you for coming.
that feeling like you're going to vomit comes up into the esophagus, and you get like that burning feeling in the chest, and that is often referred to as heartburn. The pain is often worse after eating, in the evening, or lying down or bending over. Other symptoms of GERD include a sour taste in the mouth, bad breath, belching, and difficulty with pain when swallowing. Now I'm going to pass it over to Mirna.
Thank you. Give me a second. Okay, so treatment for GERD, we have the OTC medication, or that's the over-the-counter medication. So we have the antacid that neutralizes stomach acid, medication to reduce acid production, and medication that block acid production and heal the esophagus. And if it's worse, they also can do surgery. And PSW supported measures, along with any precaution they need to be aware of when caring for clients with GERD. We have to always follow the care plan. But based on given signs and symptoms, I have here some PSW measures or PSW supportive measures. We have dressing. So considering client's preference, show him or her at least 2 options of loose-fitting clothes. So why loose-fitting clothes? It is because tight-fitting clothes gives, or it puts pressures on the client's abdomen and the lower esophageal sphincter. So always give, so when the clients have GERD, always give a non-tight-fitting clothing. Another one is preparing meals and feeding the client. Avoid foods and drinks that trigger reflux, like fatty fried foods, tomato sauce, alcohol, coffee, chocolate, mint, garlic, and onion. And as much as possible, since some clients with GERD have difficulty swallowing and regurgitating, offer them a full liquid diet. We have the one in chapter 28, page 585. And also allow the client to eat slowly and chew thoroughly the food. And do not let the client lie down after a meal. So wait for at least 3 hours after eating before lying down or going to bed. So maybe during those hours, you can watch movie together or read or whatever the client wishes after their meal. Also, provide oral hygiene to the client, especially after emesis. Another one is positioning. If the client regularly experiences heartburn while trying to sleep, put the clients into Fowler's position by elevating the head of their bed. We have that one in chapter 25, page 510. And if you can't elevate the bed, you can insert a wedge between the mattress and back spring to elevate client's body from waist up. And always report immediately to your supervisor that the client has vomited and your observation. And I also want to talk about the risk factors or the condition that increases risk of GERD. And this include obesity, bulging of the top of the stomach into diaphragm, or the hiatal hernia. I don't know if it's correct. I pronounce it properly, so bear with me. I'm not doctor by profession or a nurse. And also connective tissue disorders such as the scleroderma. We have that one in chapter 37, page 849. And also we have delayed stomach emptying. And factors that aggravate or worsen acid reflux, we have smoking, and this is me, eating large meals or eating late at night, and eating certain foods that trigger such as fatty foods, and drinking certain beverages such as alcohol, carbonated drinks, and coffee. And also the last one, taking certain medications such as aspirin. So some of the one I mentioned, I got it from Mayo Clinic. Thank you.
Really nicely done. Thank you, you two. Excellent coverage of Gerd.
Let's go. Thank you.
I was really happy. Oh, Nastran, go ahead.
Ganda ng
What
talent
was
yung
the
disco la.
page 849 Miriam said that
Turo ako mag-guitar,
what about
madam.
you said we have in 849. If you look at your notes, there is some problem with his skin.
Yeah, we have this scleroderma. That's a hardening of the skin and connective tissue.
Right. So how it's related to GERD?
Alison will answer the question. I got information from Mayo Clinic.
Okay, I'll take a peek because that was on my list of questions to ask as well. To come back. So I'll go and take a peek to what she read on Mayo Clinic.
Thank you.
Something that I wanted to mention that was a really positive piece was they brought up the positioning. Okay, so positioning is to come bring them to fowlers, semi-fowlers, high fowlers. So we're raising the head of the bed, right? So from a gravity perspective, can you imagine what we're doing if I'm laying flat and this is stomach acid? And is it near my esophagus? If I raise my head, where does the stomach acid go? Oh, further away from the sphincter. So that's why we like that first thing that you can do, kind of raise the head up, start to sit someone up. That's a first step that we can do, is start to sit someone up like that. So some people might sleep with some extra pillows so that they sleep in a raised position. Okay. The other positioning piece for Gerd, sorry, I keep saying Gerd. It's my cousin's name. Gerd, like that, not Gerd. Like actually, her name is Gerd. And it's Gerd, the acronym is Gerd. But the stomach is kind of like this, okay, with the esophagus. So the other recommendation for sleeping and resting is actually the left side, because then that esophagus tube is on the top instead of on the bottom. So that same fluids thing that we're playing with, if the esophagus is up here, less chance. If the esophagus is down here, more chance of that acid going into esophagus. It's not straight up and down. When we look at the body, the way that the organ is oriented is more like this. So we'll recommend people not only to raise their head a wee bit, but we'll say sleep to your left side. Because we want to put the esophagus part where the esophagus attaches, we want it up higher a little bit, away from the stomach contents to reduce the risk. Make sense? It's a little thing, but it's just a body positioning. What am I thinking about as a PSW? What's a change that I can make for my client? I can help them to turn in position to their left a little bit. I can raise the head of the bed a little bit to see if they can be a little more comfortable, right? You see how that becomes part of my spidey sense, part of the things that I can do to support clients. So if Master Ann just tells me, oh, Allison, I just ate so much food and I've got heartburn. I say, why are you lying down on the couch? Sit up. Come, bring your head up. Maybe you will feel less heartburn. Yeah, Master Ann?
How about heart problem? Which side is left side is better to lay down, or
The heart isn't related to the stomach acid. This
I
is
know
stomach acid piece, right?
problem with heart, like heart failure or which position, doesn't matter.
No.
Because they are related to the water somehow too.
Pressurized system, no. So that whole system is under pressure, so it'll keep going. But this one, your stomach contents, definitely we can do a little bit of modification with body position for where that water, where the stomach acid's sitting. And that's not a perfect fix by any means. No one's saying that that's a perfect fix. Just as one of those helpful interventions, right? Some people it'd be very helpful, and other people it won't be as helpful, right? Yes, of course, sure. Absolutely, yes. There are absolutely better positions to be in for cardiac and as well as respiratory concerns and comorbidities for sure. For sure. My answer for the class, just to clarify, my answer for Nastaran was related to the fluid in the stomach, the contents of the fluids being moved depending on what side we are laying on, just specifically that. Geez, you guys were good. Yes, Charmaine. You're here now.
Can you?
Oh, well, you did, but then you went back on mute. You were here momentarily. Yeah.
Right. Is this the same thing as acid reflux?
Yeah. Yep.
Okay, because I realized that if I eat or drink but if I drink like hop or something like that, or other juices, when I lay on my whatever, it comes up. But if I drink water, I'm fine.
But carbonation bubbles in your stomach, and it doesn't sit well.
Right, and it's like I'm drowning.
Charmaine has learned a lesson that she should not be drinking soda products, right? Right? Eliminate the soda. And you know what? We like soda as a treat for sure, but that's a good habit to eliminate the soda from your diet. Or let it get flat a little bit. Or just get rid of some of the fizz so it's only half fizzy if you want it for your own personal, if you still really want to have that soda. See if you can put less, or if you get one of those soda streams where you make your own fizz, just put a little bit in and then you just get a little bit of the fizz instead of I find that the soda cans and the bottles, there's so much carbonation in them. I prefer like a water like a Perrier doesn't even have close to the same bubbles as a soda, I find. So there are different options for sure. But yeah, it's just it's acid reflux. So there's like, as we go through the, which one, but what good, sorry? The soda streams? We have it, I like it. Mark doesn't prefer it because he wants real soda, but it's absolutely comparable. I know when I lived in South America, we added, in Argentina, some of the families carbonate their wine with soda water. The soda stream is the exact same as the carbonated soda water, for those of you that come from places that people do that. Same as the carbonated soda water at home. So not like the Perrier where you can taste the salty in it and stuff like that. This one, no, it's just literally, I take the tap water and I put it And it's got soda, and then I put a little drops in it or something like that to make flavor. So, yeah, Charmaine?
I took my hands down, didn't I?
Well, it's up again. I'll take it down for you.
Thank you.
Oh, I have a note, a star. I had my page turned, so I had a little star for vomiting, for emesis that I wanted to mention, and I forgot to. But talking about Gerd reminded me. So when I'm thinking about the anatomy of the body, a way to imagine how the different sections are sectioned is like, there's like a little door. Okay, it's like a one-way door. So my esophagus, up here, there's a one-way door. I swallow that food, it goes down the esophagus, right? Not down my trachea, not in my breathing tube, I want it in my eating tube. So I swallow, the door opens, the food goes in, goes down, and there's a little door to let it into the stomach. And then there's a little door between the stomach and the intestine, okay? Crayon description, little doors. One-way entrance, you only go one way, right? Peristalsis, starts, ends, we go through. So something's got to be going on if it's going to come the opposite direction, right? Now, when we were talking about emesis, I mentioned if you see blood or you see stuff in there that looks weird, you should report it. But I'm going to link together a few things here. If things cannot pass through the system the direction that they're meant to, which direction are they going to go? What do you think? Yes. Opposite. So, do you think that it's possible that fecal matter could be present in emesis, in the vomitus? Yes. Yes, there can. Okay? So, it just further goes, you're not going to see it. You may never see that, but you may. At the end of the day, it just kind of comes down to that, like, I'm seeing things that I shouldn't see, that I'm not expecting, right? That's not normal to have that in some vomitus, right? It's that ring, we need to call, we need to report, we need to document something serious is going on. So if you're noticing these kind of things, then we have to make sure we're having that communication, okay? You can imagine that if there's fecal matter coming out this direction, something pretty serious is going on at this point, right? Because we might not know what's happening, but I know enough that that's not normal vomitus. That's not normal emesis, okay? Makes sense? That spidey sense, that PSW spidey sense that we're creating. We're all going to be like expert Spider-Man. Yeah. No, Nausea, the doors might not be broken. Maybe, I don't know, maybe I have an obstruction in my bowel, for example. Maybe something can't pass through. So it's just going to get backed up. And then it's not that the doors failed. It's just that there was so much stuff that the doors couldn't stay shut anymore. In that sense, not that like, does that, sure they failed in the moment, but I mean that there's not like a pathology on the door. The door is not broken itself and things are just going wherever they want. It's an actual backup and there's nowhere for the garbage to go. It's got to come out somewhere else. This is going to go back out the system, okay? Yeah, it could be a tumor. What does that mean? Obstruction, literally, obstruction. It's looking for another route. Yeah, if you have a constipation that's so bad that it cannot go anywhere, where is it going to go if you're constipated? Do you stop producing fecal matter if you're constipated? No, you just produce more, it just gets backed up, right? More and more. Why do you think I want to know if your client is constipated for 3 days? Why do you think you're reporting on their bowel movement every day? Because our clients are not, what do we know about bowel movements and stuff, right? We need to be mobile, we need to be, right? So those risk factors, our clients have lots of these risk factors, right? So your monitoring of all these things are really important. They're telling the story of our clients. Because we fix the constipation and then they go, Tracy. The point here wasn't to have a big long discussion about what is a bowel obstruction, partial bowel obstruction, and interventions for those things. The piece that we're potentially going to run into is that, right, like that after. So if you are taking care of your client daily and they're vomiting all of the time, or they're constipated every day, I'm just want to remind everybody there's a bigger picture here than just like, oh, you didn't go to the toilet today. Well, have they been not going to the toilet every day for 2 weeks, for 4 weeks? That's a problem, right? So I just want to remind us, it's not just necessarily like blood. There could be other things in that vomitus, in that emesis, okay, that are just as important, right? They're telling a story, okay? Yeah, Charles went on with that, that crayon example. If the door itself is broken, that itself is a separate issue to malabsorption as well, right? So, but it can be an issue. Veronica?
Thank you. But is possible someone can be constipated for 4 weeks? It's not super dangerous.
That's what I'm saying. It's super
But I mean,
dangerous. You need to report every day.
In 1 week, we have to address the problem. Or in 2
Yeah,
days.
But what I'm saying is that if the PSWs are too lazy to report that the client did not poo, they're just lying. Bowel movement. They check their tick list because you're so busy and you don't care. You just go through, you go to your POC and you tick every box, bath, oral care. Do you know how many PSWs tick oral care and never did oral care on their client? Do you know how many? It's not acceptable. It's lying in the documentation. Right? So if you're tick, not to pay attention, oh, well, you know what? She probably pooped yesterday. It's fine. I'm off for a week. I don't care. I haven't been here for a week. I don't know she didn't have a bowel movement, right? Number one is like we're checking our clients' documentation. We're checking the charts. We're seeing. That's kind of one of those things, right? I need to know. And if they haven't had a bowel movement in a couple days, hopefully the nurse is coming to bring the medication to make them have the bowel movement, right? And so, Veronica, we're going to be having our, meeting in the morning and say, like, Adriana didn't have a bowel movement in 3 days. I'm giving her the medicine. Veronica, you're expecting a big bowel movement episode happening here with Adriana today at some point because I'm going to give her the medicine to make her go. So I will have my eyes on her so you don't have a whole blowout in the bed. Right, and linen change, right? But if you keep not doing your documentation, if you don't do your work, how do I know that Adriana didn't have a bowel movement from 5 days? If it says that she pooed every day, you washed her, you changed her brief of bowel movement every day. How would I know she's constipated? She's cognitively impaired. She's toileted by staff. She wears a brief. Staff need to tell, right? Staff need to report. That's why we have all of this documentation. Don't lie in your documentation, everybody, please. Right? If you're not able to manage your time, we need to work as a team. We need to figure out how to get it done. And we can talk to management. We can look at staffing issues. We can look at those things after, but we have to communicate. It's better to say, I couldn't get to her oral care because I was so busy. Right? Maybe on evening shift, I can do oral care for you. Like, do you know what I mean? Have that communication rather than us just lying. Don't lie in the chart, right? That chart is telling a story. The doctor, when they get the chart and they see that the lady had a bowel movement twice a day for 2 weeks, right? Well, it's not a bowel obstruction. There's nothing wrong with her bowel. She's going every day, right? So the answer, Veronica, is it shouldn't happen. It shouldn't happen. Shouldn't. But it can. And we could, of course, see complications from other things that would result, right? But we're watching because the person might be high risk. So we would be hopefully watching to make sure, right? We're making sure that we're giving them softeners and things like that so that they don't get a constipation or something else. But yeah, was it Nasrin that somebody wrote a tumor? Sure, it could be anything. If there's a blockage, I don't care. If there's a blockage, you stick a rubber ball up there and plug it, like, I don't know, whatever. It's not working, right? Yeah, some people are just in it for a paycheck. They're not actually in it to care for people, right? They're in it for a paycheck. Nastran.
I just have a dictation problem. It says client's immediate environment. What does it? Remove vomitus from the client's immediate environment.
This is this is my immediate environment. Is this room that I'm in? Type of thing. So it depends on where your client is, but if they went and then you leave it on their table, I can see it, I can smell it. That's not good. I don't want it. So just meaning like get it out of the room, take it to bathroom, dispose as soon as you can. Try not to leave it to stink up the room. You wouldn't want family members to come in and see it. You know, that kind of thing.
Or they splash to the surrounding, clean the surrounding too. It means the environment around them.
Yeah, very good. Taking of oral care by PSW and long-term care is too rampant. The only way to stop this, if the clients themselves have their own POC, just my opinion. I think the only way to stop it is to make sure is for people to just do their jobs. Having a computer in somebody's room doesn't change the fact that that you're doing their teeth or not, in my opinion. I think that it should be part of your to-do list with every client, at the very least. To put the foam one, right? You should at least let people have a Listerine. If I tell Nashra I don't want to brush my teeth today and I'm well, that's fine, but maybe can you at least give a Listerine rinse? That's a really nice way to meet halfway for your client who's saying, no, I don't want to. Okay, well, what, let's just wash your mouth out. Perfect. At least it's one thing. Then when you go to POC later, you say, well, client refused toothbrush, didn't want oral care per se, but we did a mouthwash with the rinse. At least you did something, right? It's better than nothing. Okay, next, gallbladder disease of the gallbladder.
Thank you, madam.
Gallbladder is what it's a small, tiny sac. Well, that's way too big, right? I'm not making a small with my hands. That's not fun. Small in comparison to my big son. But it's a small little organ, okay? And it stores the bile, okay? Stores our bile. And the bile, that's the stuff that can be turned into stones. The gallbladder stones. Okay? These stones, cholecystitis, okay, is the inflammation. Cholecystitis is the inflammation that you get. Okay? The stones can create a little mini blockage. Oh, what do we know? When we make stones in the body, they can block tubes. Jeez. So we can get these little stones, they can get stuck in the tube, and that's going to, though, affect the bile that's coming out of that gallbladder. Okay? So if we've got stones in there, we're going to have abdominal pain, nausea, vomiting. You might see jaundice, where they turn yellow colored, yellowish looking. And I mean, people who are jaundiced are yellow. They're yellow. I don't mean you have a bit of a yellowish all over the hue. When I charted on a lady that was jaundice, and the language that I used in the chart was literally, she was highlighter yellow. Her skin looked like yellow highlighter yellow. She was glowing, in my opinion. She was so yellow. Nestran, comparatively, right? It wasn't normal skin color. You just looked at it and said, that's not normal. You knew it wasn't normal. She was yellow. So it was really not normal. But jaundice can be very subtle as well. So we'll often see it happen in the whites of the eyes first, because it's white, the eyeball. So we can sometimes see it there. Yeah, absolutely. Good specimen formation. Yellow skin. she's a highlighter, walking highlighter. Send her as a crayon for Halloween. Oh, that's funny. What else did I want to know? Yeah, lots of pain. Anyways, I have a friend who suffers with these stones, and she goes through episodes of severe pain. Really bad pain in her abdomen. Just awful. Like she wouldn't be able to come to work if she was having a flare up. It was just so bad. Okay. Yeah, so it might be a little more on the mild side, right? Everything is that spectrum depending on the person and how it's advancing with them. But you might have that like kind of Gerdy pain, right? Because it's right all up in that same area, right? So pain might be in a little bit of a few locations in here. You might have that nausea and vomiting, like she's like I mentioned already. But these type of clients are going to be really complaining of a lot of pain. That's lots of stuff, lots of gas, nausea, and there may be, like Tracy mentioned, gallbladder might be removed, right? Sometimes, right, when they might try to change your diet up a little bit and try to do things like that, manage you a little bit before they go and yank it out. But ultimately, same kind of thing though, we need to be documenting, right? So asking about that pain. Oh, that abdominal pain is much worse today. So, oh yeah, it's much worse today. I have much more. So I want to be thinking about that. Oh, they're telling me these things. I need to document them into the chart. I need to communicate that. Okay, we want to capture it if we can. Next, I'm going to talk really quickly about liver disease. Okay, hepatitis, liver-itis, right? Hepatitis, liver inflammation. Okay, could be bacterial or viral. We're going to follow standard precautions. Okay, cirrhosis is the damage, right? It's that scarring, damaged liver, okay, liver tissue, and that's because of this persistent liver disease that's happening, this chronic inflammation, this hepatitis inflammation, okay, causing scar tissue buildup. Okay, so as the liver gets replaced with scar tissue, its function decreases. Make sense, right? Can totally make sense of that. All of us, we're seeing this body as like this really, all of these systems really interconnected now. I think the whole class is seeing this happen, and so it's often this cirrhosis, this damage is often caused, or resultant of alcohol abuse, but it's not the only reason. We have viruses like hepatitis C, okay, that can cause this inflammation. Some people have autoimmune disorders too that can cause that. I have a friend I know, she has a autoimmune disease and it attacks her liver. So she's got cirrhosis now because of stuff that's going on that's not related to alcohol. She doesn't drink because she has stuff going on with her liver. So she's reducing risk, right? Alcohol intake. She doesn't smoke. She's trying to reduce the liver because reduce those risks because she's got that issue with her liver. Okay, so it doesn't have to be because the person is an alcoholic. Please don't go down that assumption route. We can't. Right, so the hepatitis A, B, C, and that can do that inflammation in our liver too. Asmara, you're next.
We have the hepatitis, so I think me and Adriana.
Hepatitis! I thought that was in the communicable diseases, not in this one, but we can do it now. It's a liver disease. I'm happy.
can do that. We
Absolutely.
prepare for today. Sorry.
Okay. You want to go now? Now's your time. Bob's your uncle.
Okay.
Happy.
Thank you.
Yeah.
Okay, hepatitis means inflammation of the liver. The liver is a vital organ that processes nutrients, filters the blood, and fights infections. When the liver is inflamed or damaged, its function can be affected by heavy alcohol use, toxins, certain medications, medical conditions, bacterial, viral, parasite, or transfusion of incompatible blood. So there are three major viruses that cause hepatitis in Canada. Hepatitis A, B, C, all can be passed from one person to another. Hepatitis A is common among preschool and school-age children than among adults because the virus spreads easily among children. Poor hygiene practice after defecation leads to contamination of eating and drinking vessels, toys, and other surfaces. Also, young children are often put their hands, toys, and other items in their mouth. Hepatitis B and C virus are present in an infected person's blood and certain body fluids like semen and vaginal secretions, and can be spread through sexual intercourse or by sharing needles with an infected person or childbirth from the mother to the child. And also needle sticks injuries and by direct contact between open skin and infected blood or body fluids. Adriana can say the symptom and the...
Yes, thank you, Asmara. So hepatitis, all viral hepatitis have several symptoms. It could be completely asymptomatic, and the person never knows that he or she had the sickness. But others have jaundice, anorexia, abdominal discomfort, clay-colored stools, tea-colored urine, nausea, vomiting, muscle pain, drowsiness, irritability, itching, diarrhea, general ache, redness, and swelling in the joints. Hepatitis treatment varies. If the first thing to think about treatment is preventive. So fortunately, we have actually vaccines against hepatitis A and B. Hepatitis C doesn't have any vaccine, but there are currently several research trying to find one. So we must promote prevention. We must promote every person take hepatitis A and B vaccines. So milk cases don't require any medication, only it's essential to provide rest, good nutrition, get enough calories, eat more high-calorie foods. For instance, drink fruit juice or milk rather than water. Drinking plenty of fluids is important to prevent dehydration if vomiting occurs. Prevent abdominal damage to liver. Avoid alcohol and the use of over-the-counter medications. Acetaminophen, Tylenol, Tylex, Tempra is one of the worst over-the-counter medications that exist, have the risk for injuring the liver. It's very important to prevent transmission to others. So the person who is sick must wash their hands thoroughly after using the toilet and don't prepare food for others while he is infected. Some people with acute hepatitis can develop acute liver failure, which can lead to death. Hepatitis fulminant, it is not frequent, but it can happen. Chronic hepatitis B infection can be treated with medicines, including oral antiviral agents. Treatment can slow the progression of cirrhosis, reduce incidence of liver cancer, and improve long-term survival. The World Health Organization recommends the use of oral treatments like tenofovir or entecavir as the most potent drugs to suppress hepatitis B virus and try to diminish the risk for getting cirrhosis or even cancer liver. Most people who start hepatitis B treatment must continue for life. Liver transplantation is sometimes used in people with cirrhosis and liver cancer. So before Asmara talk about our role as personal support worker, we can share something in here. Could you share my screen?
You may go for it.
How I can do that? Sorry. Because I took that, share content. Oops, I can do that. ¿Cómo puedo con... Ya quité la cámara. How I can do that? Share my screen. Lo que está atrás, abajo. No, this one. I prepare a YouTube video. This one. Okay, now you can see my screen.
Yes, we can see it.
Thank you very much.
Put the voice more. We can't hear it. Still no voice. There's no. We can't hear it, Adriana.
Breakfast tayo, guys. Let's have sandwich and coffee. What's going on here?
I've posted it in the chat here as well for everyone. So you can come back and review it again. Or Adriana, I don't know if you can hear me. If you want, I can present from mine because the volume isn't working from your computer here. This video is so good. You found such a good video. Is that okay with you? Do you mind? I will present it from mine. It's such a good video.
I can read her lips. It says for sure, for sure.
Okay, let me do it mine here for us here. Let's go here. Nope, that's wrong. You, here, here. All right, am I up? Yes.
Yes, you are up.
If you have hepatitis A or B, your liver is inflamed because you have been infected with either the hepatitis A virus or the hepatitis B virus. Your liver is a soft, flexible organ that performs many important functions. The functional parts of your liver are called hepatic lobules. Your hepatic lobules filter all of the blood in your body. As the blood passes through, your hepatic lobules break down harmful substances. Remove bacteria and worn-out blood cells, and forms clotting factors that control bleeding. After a meal, your liver stores nutrients to provide your body with energy when needed. Your liver also makes a substance called bile. Your gallbladder stores bile and releases it into your small intestine to help digest fats in the food you eat. If you have hepatitis A, the virus entered your body when you were exposed to fecal matter from a person infected with the virus. You may have been exposed to the virus by eating contaminated food or water, contact with infected feces, such as during a diaper change, or having unprotected sex with a person infected with